So welcome everyone to this very interesting webinar that we have this evening. This is Barbara Scott here. I'm Chair of the Association of Reproductive Reflexologists, and I'm hosting this webinar on behalf of the European Fertility Society as part of their series of patient information webinars. And I am delighted to welcome this evening María Peral, who is going to be speaking on genetic carrier screening. She is a specialist in molecular genetics, and she is going to be talking to us this evening about the significance and importance of genetic carrier screening for patients undergoing assisted conception and how important that may be for them. So I'm absolutely delighted to have you with us this evening. Thank you so much for being with us. I'm just going to say, please do post questions in the chat box. We will make them anonymous for you, so you are very welcome to share information. And we will do our best to answer them. If it becomes difficult to answer them and we need more information, we will come back to you. But if we get to the end of the session and have not been able to answer them, we will provide an email address for you so that you can fire away with questions after that. So I'm going to hand over to Maria and say thank you so much for being with us and for sharing your knowledge on this very important topic this evening.
Thank you, Barbara. Good afternoon, and thank you for having me and for the opportunity to give this presentation. Well, I would like to begin this talk by posing 3 questions that I will address throughout the presentation and that I hope will give us all something to reflect on. Well, the 3 questions are, if I'm healthy, why should I take this test? Would you like to know the risk of passing on a genetic disease before having children? And finally, can a result change your decision? Well, first, I'm going to talk about genetic carrier screening, and the first question is, what is genetic carrier screening? This is a test that identifies whether a person carries genetic variants associated with certain hereditary disease, even when they show no symptoms and have no personal or family history. For this reason, genetic carrier screening studies have been designed to determine carrier-non-carrier status for a specific monogenic disease with autosomal recessive and X-linked recessive inheritance, with the aim of establishing the genetic risk of offspring. Thanks to advance in massive parallel sequencing, also known as next-generation sequencing technology, it is now possible to analyze hundreds of genes simultaneously through a single genetic test. Well, next, we will review the main inheritance patterns of monogenic disease. We will begin with autosomal recessive inheritance and then discuss X-linked inheritance, as both are commonly included in genetic carrier screening programs. Well, the first is autosomal recessive disease. In this slide, you can see. Autosomal recessive disease occurs when an individual inherits 2 altered copies of the same gene, one from each parent. Well, it's a affect allele with father healthy carrier and mother healthy carrier. When both members of a couple are carriers of the same recessive disease, in each pregnancy, there is a 25% chance of having an affect child. She has 2 copies altered of the same gene, is this case. Okay, a 25% chance of having a healthy carrier child. They are heterozygous carriers, meaning they have 1 pathogenic variant and 1 normal allele of the gene associated with the disease. And finally, a 25% chance of having a non-carrier child. Sorry. Regarding X-linked inheritance, monogenic disease, female carriers have a 25%, 50%, chance of passing the mutate gene to their daughters, who will be carriers, and 50% chance of passing the mutate gene to their sons, who will be affected by the disease. And is this case, okay? Now that we have reviewed how these diseases are inherited, let's move on to why genetic carrier screening plays such an important role in reproductive planning. Okay, it is estimated that approximately 1,300 monogenic diseases, and that approximately 1 to 2 in every 1,000 couples are at the risk of having a child affected by one of them. Autosomal recessive and X-linked disease together affect around 2.5 in every 1,000 newborns. There are striking numbers that remind us how important it is to know about this disease. It is important to note that carriers generally do not experience any symptoms of the disease, yet they carry the capacity to pass the mutate gene onto their children. Therefore, without realizing it, we may transmit a serious disease to our offspring, potentially compromising their quality of life or development. And other important note is the clinical application of this study must always be accompanied by appropriate genetic counseling, both before and after the test, as well as the corresponding informed consent, ensuring accurate interpretation of results and informed decision making, whether before pregnancy, during pregnancy, or following the birth of the child. Well, there are two types of genetic carrier screening. The first is the basic panel. For men, this panel includes 15 genes associated with autosomal recessive inheritance, and for women, the same genes are included, and together with additional genes associated with X-linked disorders. And the expanded carrier screening includes all the genes covered by the basic panel, together with additional genes associated with autosomal recessive disorders. By analyzing a broader range of genes, it further reduces the residual risk of having a child affected by a severe genetic disorder. In addition, to all the genes, including the both panels, complementary analysis also are performed. This is this case. One of these complementary studies is multiplex ligation-dependent proof amplification testing of the HBA and SMN1 studies. In the case for women, analysis of the FMR1 gene CGG triplet expansion is also included. Multiplex ligation-dependent proof amplification is a technique used to detect microdeletions or microduplications in specific genes. For the HBA gene, it identifies gains or losses of genetic material, and in this way, it helps determine whether a patient is a carrier of alpha thalassemia, a condition characterized by microcytic or hypochromic anemia. And in the case of SMN1, the multiplex technique is used to detect microdeletions or microduplications, especially in exons 7 and 8. It is used to support the diagnosis of patients with suspected spinal muscular atrophy. This slide shows 15 genes included in the basic panel, along with their respective carrier frequencies in the non-Finnish European population. As you can see, cystic fibrosis is a higher carrier frequencies, and similarly other conditions such as Smith-Lemp-Opitz syndrome, spinal muscular atrophy. And in this slide, sorry, we see the X-linked genes, including the basic panel that it tests in women. Well, after understand what carrier genetic testing is, different types, and who these diseases are inherited, the next important question is who these tests are intended for. The first are couples planning a pregnancy. Carrier detection in the preconception period provides significant benefits to couples found to be high risk by enabling them to make informed reproductive decisions. Other are couples undergoing reproductive treatment who require a gamete donor. When a couple requires a gamete donation, a genetic matching process is performed between the donor and recipient based on the genetic panel. And this helps reduce the risk of having a child affected by any of the disease, including the panel, or by variants carried by the recipient. It is also intended for individuals with a family history of genetic disease. It's important, it's not a diagnosis tool, but help you to know your genetic profile. Consanguineous couples, and finally certain ethnic groups that with a higher risk of carrying a specific disease. Once we know which types of genetic variants patients are carriers of, we need to interpret the results before starting the reproductive process. For this purpose, a genetic compatibility study is performed. Well, when a couple undergoes a compatibility study, the woman is first offered a carrier screening study for autosomal recessive disease. If no pathogenic or likely pathogenic variants are detected in the genes, including the panel, the couple is considered to have a low risk of passing a recessive disorder, and the reproductive process is continued. The risk of having a child affected by monogenic disease is significantly reduced, but it's important that not eliminate completely. In other case, if the woman carries a pathogenic or pathogenic variant in a X-linked gene, we recommend pre-implantation genetic testing. However, if the woman has a pathogenic or pathogenic variant in the genes included in the panel, carrier testing is recommended for her partner. And in this case, when a couple, if a couple not mutation in the same gene, they have a low genetic risk and the reproductive process can continue. But on the other hand, if couple have mutation in the same gene, that is, they share a pathogenic or pathogenic variant in the same gene, there is a 25% probability that their children will be affected by the disease. And in this situation, the following options are considered. The first is a prenatal diagnosis in the case of natural conception. Fifth, with pre-implantation genetic testing. And finally, recourse to egg donation. Now, let us consider those patients require a gamete donation when, in cases where no variants are shared in the same genes, the match is considered low genetic risk and gamete donation can proceed it, having reduced the risk of having offspring affected by considered hereditary disease, including the panel. And in this situation, only a residual risk of transmitting this disease will remain due to the limitations of detection techniques. In other case, when the donor and patient have pathogenic or pathogenic variants in the same genes, the match is classified as a high genetic risk, and in which case the pairing of gametes cannot proceed, and the donor must not be assigned to this specific couple. And a note important, in the particular case of oocyte donation, if the donor is a carrier of pathogenic variant in a X-linked gene, she's considered a high genetic risk donor and should be excluded. It is important to note that carrier testing allows us to identify an individual's genetic profile and the genetic risk of transmitting a disease to their offspring. But it does not completely eliminate the risk of a live-born having a genetic alteration due to limitations of the techniques, as well as variants that have not yet been described for that are unknown. The probability that an individual is a carrier of a pathogenic variant associated with a recessive genetic disease is determined by the prevalence of the disease in the population to which they belong. Therefore, it is possible that an individual may be a carrier of a disease that cannot be detected, and this is a false negative. So carrier detection cannot completely eliminate the risk because not all genes cause a condition may be known. Not all genes cause a condition may be analyzed. Causative variants may be undetectable by the technology or analysis method used. And finally, interpretation of certain variants may change as scientific knowledge advance. It's important this slide because it's a key point by is reducing in these specific studies, it reduces the risk, but it's not eliminated completely because we have a residual risk. Okay, to close, I would like to highlight a few cases. Carrier screening identifies couples with an increased genetic risk, approximately 1 to 3%. It is a preconception screening tool. It's not a diagnosis tool. It can significantly reduce the risk of severe genetic disease in offspring. However, it cannot completely eliminate the risk. And finally, it should be combined with genetic counseling and personalized reproductive options. Well, finally, I would like to close with a quote by Francis Collins. The genome is the ultimate illustration manual for human life. Thank you very much for your attention. I hope you enjoyed the presentations.
Thank you so much, Maria. That was really it was both interesting, fascinating, and also incredibly important because I think so many patients really don't understand the relevance and importance of genetic screening until much later on their journey in trying to start a family. So one of my questions, I've been scribbling away while I've been listening to you. So one of my questions, and we have got a few questions in the chat box, but I just wanted to start with a few, was at what stage in trying for a family would you recommend genetic screening? Or is there a kind of at what stage would you recommend they begin?
Yeah, repeat the question, please.
I was asking at what stage in their journey to becoming parents would you recommend that they consider genetic screening?
Well, I recommend these studies previously having birth of child. In the case you are not aware if it's possible to other birth of child.
Okay. So kind of you're saying
during the treatment process, with reproductive process, previously is recommended, but if you don't know, but after the process
Yes.
for the other tip.
Yeah, I'm guessing a lot of people may consider this when they've already been on a long journey without success, and then they may consider genetic screening.
Claro que hay veces que los pacientes empiezan a tomarse ese tipo de decisión cuando ya han llevado un tiempo determinado.
Yes,
And I just wondered what the process was. I think patients might really like to know, if they come to see you, what is the process going to be for them as patients? What will that look like? They come to see you and they say, we'd like some genetic screening, we're concerned. So what will happen for them when they come to your clinic?
En plan, cuando vienen a la primera consulta aquí, ¿qué es lo que nosotros recomendaríamos cuando quieren hacer test genéticos?
Well, when the patients visit the first visit, I recommend presentation to this test by its important disorders to overscreen, and I think that is the first step in the first visit.
Yeah, yes. And then if they get results which are not optimal, do you provide the genetic counselling, or are they referred somewhere else for the counselling?
Well, depende.
Es así, si los
No,
resultados...
¿cómo es? Depende.
Depende.
Yeah, it depends that the patient are trabajo en clínica. Depende de. It depends to the clinic and the history personal patient.
Okay, individual to each
Yeah.
individual to each patient.
Yeah.
Okay, wonderful. Okay, that's lovely. I've got some questions here, so I'm just going to read them out, if that's okay. Shall I read them and then we'll go from there? So the first one we have is, would you advise genetic carrier screening if using donor eggs? And I think you've kind of answered that already, but I'll hand that one over to you.
The first question, no?
Yes, so would you advise genetic screening if using donor eggs?
Yeah. If Fertility Society in Spain recommends that all gamete donation perform basic genetic screening on the donors due to their prevalence, penetrance, or severity disorders. For example, cystic fibrosis. Spinal muscular atrophy, alpha thalassemia, and is recommend and mandatory for gametes donor.
Okay, so that's actually part of the screening process of the donor gamete when they're presenting. Oh, that's really reassuring. I think that's very reassuring. And then we have another one. This is more specific. So, are there any genetic screening considerations for a couple who have 4 confirmed chromosomal losses, trisomy 16 and 3, chromosome 8 deletion, and the female is 33, the male is 39, and now a recent euploid embryo, blighted ovum at 7-week scan, karyotyping normal, which has been done twice, but no known genetic issues other than the mother has a history of recurrent pregnancy loss?
Okay, in this situation, I consideration the patient's medical history, the whole medical history of patients, and in this case, it's possible that they have one autosomic recessive disorders and provoke these losses.
Okay, so I hope that answers.
I important that I see that all history medical of patient.
Yeah, of course, absolutely. You need to have their whole background. Medical history is really important. Yes, I mean, that's a very kind of brief overview of what's been happening for them. So yes, thank you so much for sending that question in. I am guessing if they want to gain some more information from you directly about what might be helpful, they can email you directly. And we'll give your email address. Yeah, we'll give get you to give your email address at the end. And then we have one more, which is how do you make sure that the screening covers possible disease which can result to hereditary disease if it's combined with their sperm? I'm not
okay.
sure
In this case, the genetic carrier screening relies with blood and no consider sperm.
Okay, so it's actually blood testing rather than testing of so that's going to be screening for both parties. So hopefully that will answer that question. The other question I wanted to ask is that you have a basic panel and an expanded panel, and how would you differentiate for patients which would be most appropriate for them?
The basic panel is includes genes of higher prevalence disorders with related with recessive autosomal disease, and expanded panel includes covered genes with basic panel, and I think that the patients choose this panel when they have a family history or to when they one day prefer calm of this mean to the reproductive process.
Yeah, so either they've got a genetic history or they just want to be.
Panel reduce the residual risk as basic panel, but the patient choose this.
Yes, yeah, that's really helpful. And we've got just another question. So can genetic carrier screening help explain recurrent miscarriages or repeated failed IVF cycles, even if all other tests are normal?
Same the question to other. I see the history medical, and in this case, if she want contact me for email and explain.
Yes, so some more background information you would need, really.
I don't know, but I don't know. Does she tests are normal, and I prefer see and choose this history.
Yes, absolutely. You need a big, a lot of background information on individuals. Most definitely. Yeah. Yes. I just wanted to ask, what did I want to ask? I think actually that's answered my next question. So I'm just kind of running through my notes that I made, and some of these have really, have really answered some of the questions I wanted to ask help. But one of the things I did want to say is, obviously, it is a very complicated topic, and probably not something that that couples might think about at the beginning of their journey unless they know that they have a genetic risk. And so I think what the information and the explanations you've given us today have been really helpful, because it will help patients to understand what they may need to consider right at the beginning of their journey, because quite often when they come to assisted conception, they may have been trying naturally for a number of years, and may not consider that there might be a genetic underlying genetic risk. So we just had another little question come in. So how long do the results stay valid, and would I need to repeat the tests for a future pregnancy?
No, the genetic testing is for all life.
Yeah, it doesn't have an expiry date.
No.
Yeah, exactly. Yeah, I hope that answers that. Lovely, good. Okay, well,
it's saying it's a genetic profile, the individual, and
it doesn't change.
Yeah,
it remains the same. Yeah, so once you have that genetic profile, I think what you're saying is it doesn't alter. That genetic profile will always be their genetic profile.
It's at karyotype, the profile where one of each of parent, and it's not changed.
No, unless I guess they have another partner. So if they if, for example, they have genetic screening with their current partner, and then they have a new partner, a new husband, wife, then maybe that might change their profile.
Yeah, if you meet the genetic profile, and if you any genes related to autosomal recessive disorder, is no problem, and the couple is a low genetic risk. But if you have other partner, I recommend this study, but if you don't have any pathogenic pathogenic variants, the risk is a population low genetic risk.
Yeah, wonderful. Thank you, Maria. And we just had another little question pop in. So, if I have already created embryos, is there any benefit to carrier screening before embryo transfer?
Okay, in this case, I recommend pgt-m, pre-implantation genetic testing, or PGT-A.
Yeah, of the embryos themselves. Wonderful. Thank you. Great. That is lovely. Is there any other advice or suggestions or support that you would make for patients who are going to consider genetic carrier screening?
No, it's K-Pons. Finally, a slide is my recommends K-Pons. It's important to know that it's not a diagnosis tool; it's a screening tool. And it no eliminate completely risk. We have a residual risk because due to limitations of detection techniques or variants. But different variants are, I don't know, but this classification scientific and scientific advance in future, this variant classified with pathogeny or lalipathogeny, and is important to note.
Yes, so it's a developing science, really, and what we're able to do, I'm guessing what will happen in the future is there will be more and more screening that you're able to do, genetic screening you're able to undertake. Fabulous. Well, we have a lovely Caroline has put your email address for us, which is lovely, in the chat box, so you'll be able to see that. So I'm just going to spell it out for people so that they are able to find it easily. So MPUIG Nuuma Genetics, Nuuma genetics.com. You can contact Maria directly via that email address if you've got your own very specific questions, and Maria will be able to help you from there and answer any more specific personal questions that you might have. So hopefully that will be helpful. I just want to wish everybody well on their journeys to becoming parents. And I just also want to say thank you so much for being with us, Maria, this evening. It's a very complicated topic, and you actually made that really understandable. So thank you very much for doing that, and for being with us. So thank you on behalf of the European Fertility Society. Thank you so much for being with us this evening.
Thanks. Bye. See you.
Bye-bye.
Bye.